Welcome to the Health Workforce Technical Assistance Center's webinar series. This presentation is entitled Using Employer Surveys to Assess Health Workforce Demand, and it was presented by Joanne Spetz, Lou Brunell, and Robert Martiniano on December 16th, 2014. Now, I would like to go ahead and take a few moments to introduce to you today's speakers. Dr. Joanne Spetz is a professor at the Institute for Health Policy Studies and in the Department of Family and Community Medicine and the School of Nursing at the University of California, San Francisco. She is Associate Director for Research Strategy at the UCSF Center for Health Professions and the Director of the UCSF Health Workforce Research Center. Her fields especially are labor economics, public finance, and econometrics. Joanne teaches in the areas of quantitative research methods, healthcare financial management, and health economics. Lou Brunell was appointed to the position of Executive Director for the Florida Center for Nursing in November 2002. In this role, she administers the center's goals, which are set forth by Florida statute that addresses issues in nursing manpower in the state. Ms. Brunell's professional activities include an appointment to the National Advisory Council for Nurse Education and Practice, which advises and makes recommendations to the Secretary of Health and Human Services and Congress. In partnership with the Florida Blue Foundation, Ms. Brunell co-leads the Florida Action Coalition, convened to advance the recommendations of the IOM report, Future of Nursing, Leading Change, Advancing Health. Ms. Brunell completed her graduate work at the University of Pennsylvania. She has worked as a critical care nurse, administrator, and educator prior to her current commitment to nurse workforce and health policy issues. Robert Martiniano is a senior program manager at the Center for Health Workforce Studies, which he joined in 2001. Mr. Martiniano has an extensive background in health workforce research and policy management, including 11 years at the New York State Department of Health. Mr. Martiniano is an adjunct professor at the Sage College's School of Management, teaching courses in Introduction to Health Systems, Strategic Planning, and Comparative Health Systems. He is also the health chair of the local NAACP chapter, on the board of the Hudson Mohawk AHEC, and on the New York State Workforce Advisory Committee, chairing the subcommittee on data and evaluations. Now, at this point in time, I'm going to go ahead and turn the event over to our speakers.
Well, thank you very much, and I want to thank you for the opportunity to participate in this webinar. Good afternoon and good morning to all, depending on where you're joining us from. I'm pleased to be talking with you today. As was mentioned, I'm from the Florida Center for Nursing, and I'm going to offer you some insight into our work as we try to capture our demand data from our nurse employers here in the state of Florida. As has been mentioned, the center was established in statute. The funding that had been from Florida statute, or I'm sorry, from the Florida budget, has been discontinued since 2010, but we've been fortunate to be able to continue our work, and we continue to work from the perspective of being a state entity so that we report all of our information to the public. So as I mentioned reports to you or information, I just wanted to let you know that you can access all of this information on our center's website. We also offer our information through reports that cover statewide as well as geographic regions. Our state, just as I'm sure is the case for many of you, has a lot of variances from one region to the other geographically. We also report by licensure level. And in the case of the demand data, we also report it by industry. The nurse workforce information, and our colleague of ours, some of you know, Jen Nooney, coined this phrase. She sees it as the nurse workforce, the nurse data trifecta. It includes the nurse supply data, which we collect during the licensure process and the renewal process, the nurse demand data, which we collect, as I'll further describe, through an employer survey process, and nurse education data, which we collect through a survey of our nursing education programs in the state. And it's these data elements then that are applied to a forecasting model and give us the opportunity to predict future demand for nurses in the state, as future supply, obviously. So our nurse demand survey. We survey every 2 years Florida hospitals, home health agencies, skilled nursing facilities, public health departments, hospices, and psychiatric hospitals. Our last survey was done in 2013, so we're looking forward to doing another survey in 2015. Our surveys include most of the items from the minimum data set that has been published by the National Forum of State Nursing Workforce Centers, and you can access those data sets from their website. There's a list, I won't go through it all, but we try to capture information that will give us the opportunity to understand vacancies, turnover rates, current challenges to filling positions, future needs as the employers identify them, as well as whether or not they are promoting certain practices which seem to be coming of more interest to us, such as residency programs or advancing education. And in fact, we also are asking whether or not their new hires are preferentially directed towards BSN graduates. This last 2013 survey response was actually on the low side for us. Prior to this, we've been fortunate to be at 30% or higher. Not sure what to attribute that to. Our lowest response rates, as you can see, were from the home health and the skilled nursing facilities. We don't try to capture to send surveys to the entire number of the facilities here in Florida. It would be an astronomical effort. So we do a 50% survey by randomizing the facilities that are, in the home health case, approved for Medicare, Medicaid reimbursement. But the information that was given to us in our survey since 2007 allows us the opportunity to trend the results and gives us an idea about what's happening and what the picture of nurse employment is in the state. And as you can see from this vacancy rates, we can see some changes since 2007. And in 2007, I think that we were seeing high vacancy rates and that employers had responded to that, though perhaps not successfully yet. But at that time, they were still implementing some retention policies to try to reduce that number. So that as we did our survey in 2009, we had two things that affected the vacancy rates, in our opinion. One being the response to those programs that employers may have implemented, but probably more pronounced is the response to the impact that the economy was having. And as we know, and is usually the case, nurses are not as likely to be laid off during an economic downturn or to lose positions, whereas perhaps their spouses are. So that we found nurses picked up more time, started working more, as well as did not retire when they may have otherwise been planning to retire. So we saw a dramatic change in the vacancy rate. Then, as you can see, in 2011 and then again in 2013, in some of our industries, we're seeing it climb back up towards the pre-existing or the 2007 baseline that we had vacancy rates. Similar demonstrations in the turnover rates, although it's not quite as dramatic as the vacancy rates had been. We notice in this slide we do show both for direct care and indirect care in the hospitals as well as in the psychiatric facilities. We feel that the opportunity to differentiate those is helpful to our employers who benefit from our survey results. As I mentioned, we'd also try to identify the growth for our industries, and so we asked the question of how many new positions due to growth are anticipated over the next year. And so though the skilled nursing facilities in this year did not provide us an adequate amount of information to report it, we did find that in the hospitals they projected a growth of 785 RNs, and then you can see the home health was just the largest growth with well over 3,000 RN positions and nearly 2,000 LPN positions. So what this tells us is that there is an anticipation of growth on the part of those individual facilities who responded to our survey, and this is strictly the growth numbers for those who responded. So we can say that this is an underreport, because with our response rate, you can see that there are many more hospitals and skilled nursing facilities and so forth who would also be anticipating some growth that we aren't reporting here. But nonetheless, it definitely gives us an idea of what's happening in our state. And the most obvious critical issue that we should be attending to is that growth in home health. We ask about difficulty in filling positions. And this is, as the 2 years ago, 2011, and the 2013 even more specifically shows, the difficult to fill positions are those that require experience or advanced degrees. So our difficult to fill, and this is probably not a surprise to those of you on the call, on the webinar, are not those positions that would normally go to new graduates, with the exception of within the skilled nursing facilities where we actually have nursing aid positions, LPNs, and inpatient staff RNs all as listed as difficult to fill positions. So they're struggling just to keep up with all of their categories of nursing positions, as is to some extent the case in the home health. But for the hospitals, hospice, public health, you're looking at the needs that they're identifying being those that require, as I mentioned, either experience and/or advanced degrees. So this tells us that we need to think in terms of, if we have a shortage, what is it a shortage of? And we feel by the information we receive from our demand, as well as combined with the information we receive from our supply work, that we can begin to see a picture that tells us the shortage is not for new graduate RNs. And that tells us we need to start looking at preparing our existing nurse workforce to move into some of these more difficult to fill positions, thus opening up spaces for the new graduates. So do we know demand? That's the question. And so we have our actual survey that we've conducted that tells us what their need is in the way of the numbers of vacancies, what they anticipate the future growth to be. So for this particular survey in 2013, the demand was, of those who responded, about 13,000 positions. Now, again, that's an underreport, we assume, because of the fact that we have not 100% participation in the survey. I look then to tell us whether or not that is a problem at our supply information and the data that we are able to analyze from our relationship with the education programs as well as with the Board of Nursing. So we have information about the gains in RNs by licensure, and we can tell that from our comparison of the 2011 cohort of RNs to the 2013 cohort of RNs, that we've had a net gain in those 2 years of nearly 13,000 registered nurses. An additional net gain during that 2-year period of just slightly over 2,000 advanced practice nurses. So if we only look at the numbers we have here, the 13,000 demand, one would think that we're just fine, until you realize and remember that this demand is an understatement. So that leads us to think, and again, I'm using the data and the information to give us an idea of what it's telling us, and it leads us to think that, in fact, we are probably continuing to develop a shortage and are continuing in a bit of a deficit from our RN populations. We also use population estimates to consider our growth and in-migration and the age of our population to consider how the demand will be affected. Obviously, increasing age is resulting in an increasing demand. The difficult to fill positions help us know how we can look at what types of nurses are needed in order to meet the existing demand. So we see that this work provides findings at the state and regional level by industry, and it does inform the workforce planning to meet healthcare needs. There, couldn't quite get the little button. Some closing thoughts, and I'll be glad to answer questions or invite comments. We do, as I mentioned, report our information on our website, and we feel that's important to keep it out there for use. We find that our data is used by academia as well as industry, workforce planners, policy developers, and interestingly enough, venture capitalists. That's something that we found out as the Florida Center for Nursing was looking at how we should approach our sustainability given the loss of our state funding, and we did engage a firm to look at that use and to help us develop a value statement about the Florida Center for Nursing's work. And they found that there were venture capitalists who depended upon our reports to help them consider their whether or not they were going to invest in healthcare in certain regions or in the state of Florida. Our information is also included in presentations and a variety of communication tools. Specifically to the demand survey, our challenges are predominantly identifying contacts at the institutions. We do work with the Agency for Healthcare Administration in the state of Florida, who licenses the industry here in our state, and they will provide us some information, but it often does not include email addresses. And we find the turnover of administrators, especially in skilled nursing facilities and home health agencies, makes it very difficult to identify a specific contact to send the survey to. We do a paper survey for this work because we don't have, as I mentioned, the employer email addresses to be able to send it out electronically. So that then is a challenge to maximize our responses, because if you can send something to someone who is by name, they're going to receive it, and they are the person who would be filling it out, you obviously can help improve the chances that they will report it. If you have to send it as a general notice to the nursing administrator or the chief nursing officer or whatever title, you often will not have the same kind of response. We do try to counter that effect, and we do utilize a strong relationship with our organizational groups who help by co-signing our cover letters, and some also provide a free membership or a free attendance at a conference that we are able to give away from in the sense of a drawing of those who, from that group, like the skilled nursing facilities who respond to our survey. So our biggest challenge, though, remains with the demand survey, the funding, in that we are looking at sustaining the Center for Nursing, and this is clearly, the demand work is our most expensive survey work in the supply, demand, and education and forecasting realm of things. So, and that concludes my presentation. I'd be glad, as I said, to answer questions now or even perhaps later. Our contact information is enclosed. And again, as I said, you can access all of our information on our website. So thank you.
Thank you, Mary Lou. And we'll go ahead and reserve questions until after all the speakers have spoken. And so at this point in time, Robert, we're going to move on to you.
Are you putting up my slides, or am I?
You are.
Okay.
Oh, hold it.
You have them.
Yes, they're on the tab under Employer Demand. Just click on it.
Yeah, I got it. Okay.
There you go.
Okay, so good, as Mary Lou said, good morning and good afternoon, depending on where you happen to be. So I want to take a more global view of demand surveys, not so much focusing on one occupation. The center's been around for almost 20 years, and we work with the federal government, the national government here in New York, with provider organizations and with membership organizations to help them understand workforce issues and help develop policy around workforce issues. So today I want to specifically talk about the demand survey, and it's part of a bigger whole, which I'll go into. So on an annual basis, we do a report, and as with Mary Lou, we do it regionally. So we actually have 9 or 10 regions in the state, and we show the data by these regions. And we look at both secondary data and primary data, which is the demand survey. and we try to describe what's going on with the healthcare workforce. So we look at supply data, educational pipeline data, projections, and again, and employer demand data to try to give people a broader picture of what's going on in the healthcare workforce. You know, we understand that our data is a couple years old, the secondary data we use, and so we really do try to stay current by asking what's going on in terms of recruitment and retention, and again, I'll go into a little more specifics with that. And by the way, these and our other reports can be accessed on our website. Okay. So again, as I said, the report provides things regionally and statewide, and we look at a variety of different indicators to try to give people and policymakers a broader understanding of what's going on in New York in terms of healthcare in general and the healthcare workforce and how the two of them come together. So we include basic demographic and health outcome and status information, again, in addition to our workforce information. We just started in the last couple of years starting to do more with physician data in this report, trying to explain to them on a regional level at least, you know, how many they have per capita. And again, we do use the Department of Labor regions, since a lot of the data we get from them, and they only report, I'm hearing people may not be hearing me so well, and they only can give us data on the regional level. Okay. So our employer demand survey, who do we work with? We work with the hospital associations, nursing home associations, home health care agencies, and FQHCs to try to understand workforce issues in each of those settings. We do use different methods. So for a couple of them, we actually do paper. It's a one-page fax-back survey, and we'll actually give you an example of it. For hospitals, we actually do an electronic survey in conjunction with Haney's. And for FQHCs, we work with Chicanes and do actually a fillable PDF form. So we send them to their main sites, and there are about 60 in the state. And so we get back either the form or the data. So again, depending on who we work with, it also defines the length of the survey as well as the collection tool. So what do we collect? We ask them about recruitment and retention issues on a Likert scale, 1 to 5, 1 being this is not a problem to recruit or retain, 5 is this is a very big problem to recruit or retain. We also ask for the reasons why there's this problem. We ask about other type of issues, like we ask about do they have problems with off-shift workers? So is it not so much an issue of we can bring in an RN, an LPN, or whatever, but it's really nights and weekends that we're having problems. We also ask about bilingual workers. So and we ask for what specific languages are they having problems with. So we get the normal ones of Spanish, but we've gotten Russian and Italian and Creole, Hindus, Mandarin, and a number of other languages, depending on obviously where the organization sits geographically and what people they serve. So we really do ask a number of broad questions to try to get them to give us the information that we can then describe back to the industry. This is just kind of the top half of our home care survey, and as you can see, we have a number of occupations. Again, we ask the recruitment and retention on the 1 to 5 scale, and ask them to check off the reasons why. We actually work with the home care industry in this case, and we look at last year's survey or previous year's surveys to try to understand what occupations should we include and exclude. Because a lot of times we'll find that based on what's going on in the economy and changes in healthcare, we may have to add a new title or we may have to take a title off that doesn't seem to be an issue anymore. As I said, we do work with a number of the provider associations in New York, and we get significant collaboration from them. We We work with them. They help us develop the survey, help us publicize the survey. We'll endorse it. In case of Haney's and Chicane's, we actually have a more in-depth survey that we give them additional data that we actually don't use, but they use for their purposes where they're members. And again, as I said, we do collect in a number of different ways. And also, depending on response rates, the organization may actually help us reach out and improve our response rate when there's a problem. So one of the things that's been going on in New York and probably most other states is, as ACA monies come out and as some of the policy changes in New York have been going on, there's these emerging titles, care coordination, patient navigator, community health workers, and health coaches. And these aren't generally titles that there's secondary data on. So we're finding difficulty to understand what these people do and how to define them. So one of the things we've been doing is asking, using this mechanism to get more information on these emerging titles. And we ask them about their qualifications, what their required qualifications are, required education, required years of experience. And then we also ask them about what functions or tasks we use. As we've been working with a number of organizations, what they've been telling us is a couple of things. One is the titles can be the same across organizations, but they're doing drastically different things. So we really want to understand their functions. So rather than focus on the titles, we say, all right, here's the title, now tell us what they're actually doing. The second thing we were told is sometimes funding stream defines tasks and functions. So we could have side by side two patient navigators or care coordinators, but they're doing different things because their funding stream or the grant that they're on requires different things. So we really are trying to use this tool to, again, to understand these emerging titles. Okay. All right, so next. So what have we found from our last survey? And I think Mary Lou kind of hit on this too. We are finding that there's a huge need for experienced RNs across all settings, and we find that nobody's having trouble recruiting and retaining newly trained nurses. We also know that hospitals are also having problems with clinical lab technologists. It's in the state, they just changed, probably 6 or 7 years ago, changed the licensing requirements, and it was an occupation that recruitment and retention just started becoming an issue because of these changes. Nursing homes reported issues with a number of the different therapists, and across all settings, they talked about difficulty retaining paraprofessionals. We know that paraprofessionals are really easy to recruit, but they're not so easy to retain, and we've seen that in the data consistently over the last number of years. And even geographically, we see differences with New York City having much easier time recruiting than upstate, recruiting CNAs and home health aides than upstate, but having similar difficulties retaining them. So some closing thoughts. So again, as I talked about this, these demand surveys are a real good way for us to get real-time data that's not being captured in other secondary data sources that we're using. We're able to use our demand data as well as the other data to really inform workforce issues in the state and help policymakers and stakeholders start looking at policy issues around healthcare in general and the healthcare workforce. Thank you, and look forward to any questions once Joanne's done. Thanks.
Thank you, Robert. Joanne, I've now just made you the presenter. To access your slides, go ahead and click on the appropriate tab at the top of the screen.
I am looking for which.
It's at the far right.
It extended off, yep, the way my screen was. Perfect.
Ah, yeah, the resolution. Okay.
There we go. All right, thank you very much. So this is Joanne Spetz at the University of California, San Francisco, and I'm at the Center for the Health Professions, as was mentioned, and also the Philip R. Lee Institute for Health Policy Studies. And I'll talk a little bit about what California is doing, but I'm not going to go into as much depth because there are a number of places where I can say this is pretty much what Florida and New York have been doing. And the fact that a lot of us have independently arrived at very similar methodologies tells you something about what kinds of methodologies you might want to start with if you're going to launch your own surveys. So California does surveys too. Our surveys are hospitals focused. We have simply not had the resources to do work outside of hospitals, although we have discussed it. Most of this work has been supported by the Gordon and Betty Moore Foundation, and their focus is hospital-based nursing care, so that has really driven our focus. We have two different components of the survey. One is a HR survey that is done by the Hospital Association of Southern California. They had been doing this survey for a very, very long time, but had never made the data publicly available. They would generate reports with summaries for Northern California and Southern California and make those available on their website to their own members through a password-protected section. But they did not make them publicly available. Our State Nursing Workforce Center did have access to that information, and at times, as needed, would use it for workforce planning purposes in the state. But they didn't have the kind of broad accessibility as New York and Florida have had. We then began a survey of chief nursing officers that really built on work that our State Nursing Workforce Center had done. They had done several surveys on a shoestring budget and then had piloted a survey with support from the Moore Foundation. And then the foundation asked for all of us to partner together because our group has very strong survey expertise, and of course our State Nursing Workforce Center has just such a breadth and depth of knowledge and experience with this that as a team it's been really effective. What was interesting is that the first year we did the CNO survey, we included many questions from the minimum data set recommendations of the Forum of State Nursing Workforce Centers. And it turned out that for chief nursing officers, those questions were often hard to answer. They had to go to their HR departments to get some of the data, such as number of vacancies, number of hires, number of turnover. And so after working with the Hospital Association for a cycle of the survey, we all agreed that it would be far more efficient for them to share with us their raw data file and then for us to share with them our raw data file rather than us ask the same respondents the same questions over and over again. So in the end, we've had these two components where they are mailed to different people within the hospitals. This collaborative work has been going on now. We've had 6 surveys with main annual surveys, and then we've had a couple of mid-year surveys. So one of the questions we ask, much as New York, is overall perceptions of the labor market, and we're using language that I think was initially used by some efforts to examine the pharmacy workforce. And so you can see over time here with 2010 being the first year we did the survey and 2013 being our most recent year that has been fully analyzed, that there has been some increase in the share of hospitals that say they have high demand in the red color, and at least between 2010 and 2012, there was some decrease in the share of hospitals that said demand was less than supply. It looks like in 2013 that there was a little bit of a reversing of what appeared to be improvement in the labor market. Prior to in 2010 and then also in 2013, the average response is really leaning a bit towards there being a bit of a surplus. It seemed to balance out more by 2011 and maybe move into a shortage by 2012, but now that's reversed. One of the concerns that we had about these overall data is that a nurse is not a nurse is not a nurse. And so this is very reflective of what other states have done. We asked for the first time in 2013 differences between new graduate demand and experienced nurse demand. And the results really startled us. They were much more stark than we expected. across every region of California, the respondents on average indicated that there were far more new graduates than jobs available. But conversely, in every region except for the San Francisco Bay Area, they also indicated that there was more demand for experienced nurses than supply for experienced nurses. I think this is what we are hearing anecdotally in the labor market, is that hospitals feel like the demand for nurses is rising, but they don't want to hire new graduates. They want to hire nurses with experience. And there are a lot of interesting policy and employment ramifications that come from that because, of course, the new graduates will never get experience if nobody is willing to ever hire them. We also ask employers about their expectations for the next year, and these are the overall expectations. You can see that in 2012 and 2013 years that there is an increase in respondents that expect to hire more nurses next year than they did last year. So that again indicates that as the economy is improving, there is perhaps some slow improvement in the labor market. We also ask for them to indicate reasons that they might be expecting higher or lower employment. And so these are the responses for the hospitals that indicated they expected to hire more than last year, the dominant reason being an increase in census. We did not ask about it specifically, but I suspect that that is probably in part driven by the Affordable Care Act implementation. But they also pointed out things like increased patient acuity, which isn't surprising, as well as plans for care model redesign and other factors like that. Some number of hospitals also are expecting staff to perhaps reduce the number of hours that they work, and that would increase their need for hiring new nurses or new positions. For the hospitals that were expecting lower employment, again, the dominant reason was a change in census. There were a number of hospitals that were expecting their census to decrease, but nearly 31 in some also are indicating that they've got budget constraints and hiring freezes that might be at play in their expectation for lower hiring in the future. Now, these hiring expectations some people like to look at them as a way of projecting the future. And we've examined this quite a bit with the data that we have. And we found that these data tell you a lot about what's happening right now. But in general, chief nursing officers and HR directors really have a hard time answering questions about more than 1 to 2 years into the future. They tend to be very focused on putting out the fire that is burning right in front of them, rather than recognizing that over a longer period of time they might have a bigger workforce problem and they need to plan for it. Workforce planning from a state perspective or a policy perspective takes much more time. It takes time to plan for expanding and changing RN education programs. It takes time for the newly admitted students to actually complete and graduate from their programs. And so thinking about 1 to 2 years in the future really does not help you think about what your policy needs might be. So there are other resources for states to think about in terms of long-term forecasting. And given the expense that I think all of us have experienced in trying to field employer surveys, it's worth thinking about what the purpose of the surveys will be for your policy or for your work. If you're expecting that these surveys will help you advocate for long-term policy change, they probably won't. But if you want them to help you think about more immediate policy needs, such as we have a lot of new graduates who might benefit from residency programs because they can't find a job, that it can be very useful for. It can also be useful to track those kinds of policies. We have a number of questions that I did not show you but are available in our full report about whether they have residency programs for new graduates, the duration of those programs, whether they have hiring preferences for baccalaureate graduates or for graduates with specific kinds of experience. And so those questions are also useful in terms of some immediate programmatic planning. For long-term forecasts, we can leverage a lot of public resources. There are simple approaches to estimate your supply if you want to target a stable RN to population ratio. The Bureau of Labor Statistics publishes 10-year projections of demand. And those are, of course, calculated with projections of demand for all other occupations in the United States, so one might critique them, but they are readily available. There are other microsimulation-based forecasts that are beginning to be published now. And then the Bureau of Health Workforce has released their summary report on RN demand projections, and there will be a modeling tool that will be available for people to explore. So the short-term and the long-term data both matter. Employer surveys can help you understand your current state and can verify what you forecast, and your forecast would help you with the long-term challenges to support planning in that phase of that. What we found is having the long-term forecast has helped a lot in supporting nursing schools' maintenance of their expanded capacity, because if you were relying only on current reports of new grads not finding jobs, you might end up with the legislature revoking funding from some of our state programs. But because they have long-term forecasts that tell them that we do have still a forecasted need for these graduates, they're able to maintain that support. We've developed some resources to help you plan your own employer surveys if you want to do so. On this website, we have put information that we received from states that conduct employer surveys. We began with the Forum of State Nursing Workforce Centers map that is available on their website. It's a great resource that has information about which states are doing supply surveys and demand surveys and education surveys. So we contacted all the states that indicated that they are doing employer surveys and asked them about the frequency with which they do that survey, the nature of the partnership engaged in that survey process, the questionnaires and reports, if they have them posted, could we have those links? And we made all of that information available to you. So if you're thinking you might have a partnership with your hospital association and with your nursing workforce center, then you could quickly go through this list and identify states that have similar partnerships and learn what worked for them or what didn't work for them through their own trial and error. Or if you have a different kind of partnership or a different kind of strategy, or you want an example questionnaire for long-term care facilities, you can go through this to quickly find those contacts. If you know of states that we don't have included, please let us know, because we want to try to keep this up to date so that all of you have the best resources available. I believe that concludes my section of this webinar.
Thank you, Joanne. That was great. Okay, and at this point in time, we're going to go ahead and begin the question and answer session. Once more, you may ask questions using the chat panel on the right of your screen. With that said, I believe we have a question already. And this is for all of you. Why is the demand for experienced RNs so high?
Well, this is Mary Lou Brunell in Florida. I'll be glad to give you my opinion. I think that what we're seeing in especially in our hospital settings, is that the changes in payment and reimbursement for healthcare are shortening hospital stays, which we went through in the 80s and early 90s as well. And the result of that is that our patients that are in the facilities are more ill and requiring a higher level of care delivery in a shorter period of time. So that the critical care needs I don't mean critical care as in a unit, the critical needs of our inpatients would be a challenge for a new graduate registered nurse in that setting. I think that's why we're also seeing the continuing reduction of the use of LPNs in hospital settings. So I think that's one of the reasons. Secondly, in other areas such as in home health and community settings, we're seeing an increased need for registered nurses to be able to manage care and manage populations. Again, something that is more challenge for a new graduate to be able to do than someone who has gained experience would be able to do. So the demand is just for the types of skills and knowledge that someone would bring after a few years of nursing as opposed to right out of school.
This is Joanne. I think we're hearing very similar things, and I think some of the research that we have begun to see, such as some presentations I know Polly Pittman from George Washington University did, indicate that for emerging payment models and for emerging care models, such as accountable care organizations, the need is for nurses who have enough clinical experience that they can really step into a case management role effectively. So that those kinds of growing roles tend to demand some experience. And then the question from a policy perspective becomes, how do we get new experience for these new graduates when employers are financially pressed and are finding it challenging to come up with training programs or training strategies for them?
Robert, do you have anything else to add?
I mean, we're hearing very much the same things. I mean, we're being told that nurses are coming out of training and hospitals just do not believe they have the experience to be able to go into those settings with the increased acuity and the changing models of care. One of the things that I've talked to a couple of people about it in this state is they're starting to do nursing residency programs. But, you know, that gets to the issue of, so you're hiring a nurse, it's going to cost you to have that nurse on the floor for 6 months. That's really not doing patient care. But people are starting to explore that because of the issues of needing that kind of experience.
Thank you. Okay, next question. When survey response rates are low, is there a way to assess bias in the results or extrapolate the data to a region or statewide level?
Well, this is Mary Lou. I'll start again. What we do is we then look at the composition of the results, and I can use hospitals as the best example. We know from our 200-plus hospitals in the state of Florida, we then look at them by bed size and location, as in rural versus urban, and by whether or not they are considered a medical education facility. And so we have the breakdown of our hospitals by those categories. So then we look at our responders and see how they compare to those categories. And so if the closer the responders are able to be compared to the known distribution of hospitals in our state, the more comfortable we would be to be able to consider their information reflective of other facilities.
Now, this is Joanne. We've put effort into developing a master list of hospitals in California, including information about their size and location, and do very similar comparisons. We had pondered over the years of whether to do a more formal weighting scheme, but we determined that we don't really think that these data are amenable to that kind of approach from a survey perspective. But we do try to look at that. The other complication that we've encountered, and I imagine that New York and Florida have had this too, is that sometimes multi-hospital systems like to respond with a centralized survey, and sometimes they each respond separately. And then also sometimes health centers that have a more comprehensive range of services will report for everything that they do, including their ambulatory clinics and so on, whereas others will report only for their inpatient component. So we have added a whole set of questions to try to ascertain exactly what it is they are telling us about when they respond to this survey, because we were developing concerns that we were comparing apples to oranges in looking year after year. And that information was really challenging to parse out and to sort, but we do think it improved the validity of our data, and that may be the reason we saw a reversion of the labor market back towards a surplus between 2012 and 2013. It may have been that we really are capturing the data better now, as opposed to there being a true change.
Hi, it's Robert. So we do a couple of things. One is for low responses, we'll actually add regions together if we just don't have enough, rather than not report at all. So we'll take a couple of regions that are next to each other and say, all right, so if you add them together, we actually have enough of a response. With our hospital survey and working with Haney's and Greater New York Hospital Association, we'll actually weight the data based on the number of hospitals they say are within their system. So if a major hospital says, you know, I'm reporting for 5 hospitals, when some of the questions we get, we'll actually kind of weight it by the 5 to ensure that their responses are reflective of how many hospitals are reporting the data. And the final thing we do is with especially with home health, we actually will report them in multiple regions because we know they do cut across many of our regions. So we'll make sure that their information is reflected not only in their main site, but where their other sites are.
Thank you. Okay, next question, and once more, this is for all of you. Have the trends in recruitment and retention issues changed over the last few years that you've noticed?
Well, for the California data, we've seen very low turnover over the past several years since we began doing these surveys. I think turnover might have been a little bit higher in the mid-2000s simply because it was very easy for nurses to increase their salary by job hopping and bidding up their wages. But it really has felt like, looking at the data, that the 2010 to 2014 period has been a little bit more of a period of hunkering down. We also aren't seeing turnover associated with retirement at the rate that we might have expected, but of course that's supported by recent research from Doug Steger, David Auerbach, and Peter Buerhaus, where they looked at longer-term retirement patterns and have found that nurses are tending to retire at slightly older ages than in the past.
Yeah, this is Robert. We're finding similar things. You know, it was interesting because part of our major report, we also get nursing education program data, and one of the things we asked them is, are they finding, you know, how easy is it to find a job? In the mid to late 90s through 2006 and 7, no problem finding a job. When the recession hit, it went from 90% couldn't find a job to, or could find a job, to 25% could find a job. That is actually starting to just edge up now as the economy has gotten better, but again, you're not seeing a lot of turnover, I think, as these nurses, again, you know, they came back into nursing when the economy went bad, and they don't seem to have left nursing yet to open up more space. So we're seeing a little change in turnover, but not a lot. Again, as the economy gets better and better, we'll have to see how that affects it.
Yeah, I would say the same thing, except to say that our trends are showing a beginning of a change in turnover that we think may continue to increase as the economy improves. But otherwise, we haven't seen that much difference.
Thank you. Okay, next question. These are really nice examples of state-level demand surveys. What advice would you give to a state who's struggling to collect basic supply data, let alone demand data? How would you prioritize demand-side studies? What tips do you have on convincing funders and others to support demand data collection?
Well, this is Joanne. For prioritizing supply versus demand surveys, that is a really tricky question. You know, it depends on what other information you have available and how well you're able to make do with what you do have access to. I would hazard that I think supply surveys are probably somewhat more valuable to you, in that if you are working on long-term workforce planning, the supply surveys both give you a snapshot of the current working conditions in which RNs are facing, but also give you a sense or the ability to model what their long-term supply might be. Whereas the employer surveys do give you a great snapshot of what's happening currently and what might happen in the next 2 or 3 years, but you can access other resources for that, such as the Bureau of Labor Statistics forecasts, so in terms of looking at a slightly longer time horizon. So I'd probably prioritize the supply side, but I think that would depend on how big your state is, and that if you have a large state, you may find that the American Community Survey census data are adequate for your purposes. If you have a very small state, the American Community Survey probably won't have enough respondents in your state to be very useful. So you need to make that assessment. You also might find that if your state does have decent licensing records and is willing to share them to some extent, you at least can get a handle on what your overall supply is, and you might be able to make some educated guesses about what the employment rates are based on other national or state level data. But if you have a board that is reticent to share a lot of detail about their licensing files, or you are in a very small state where the American Community Survey information isn't available, I think that becomes a very compelling case to try to do a survey of nurses. At that point, you can debate whether you want to try to do a minimum data set through a relicensure process or whether you want to do a sample survey. And each of those has advantages and disadvantages that have been detailed in some publications.
Now, this is Mary Lou. I would strongly advocate for the supply being your first start. And we do have a large state in Florida, and from the big number, the American survey may be fairly close, but it doesn't help us refine it at all, as in, understanding our RN population versus our advanced practice nurses. And our supply data that we collect using the minimum data set from the National Forum of State Nursing Workforce Centers is just a phenomenal amount of data. And we know where nurses are working, and we can trend working by knowing where the nurses are and where they report working and how much they're working. So there's actually, one can have a bit of a picture of even, well, not necessarily demand, but hospital employment, for example, just by what your nurses are reporting. So the supply data, a full data collection set is extremely valuable. Our Board of Nursing we work together closely, but they were not collecting anything that they didn't need to collect strictly to answer the regulatory requirements. So that even though they would share their data, it really wasn't helpful. And in fact, it gave a large misrepresentation, because the number of licensees in the state of Florida is about 80,000 more than the number of nurses working in the state of Florida. So you really have to be able to know what you're working with.
Yeah, and this is Joanne again. I would encourage everybody to take a look at the surveys and the work that Florida has done. They really have been a leader in this. And the second state to look at is, in addition to New York, of course, is also North Carolina. They have had a very long-standing survey across multiple health professions. And those information over a long period of time really allow you to do a lot to understand what's happening in your workforce. And you can link those files over time to also look at patterns and trends over time for individuals.
Yeah, our surveys of RNs during relicensure is much better data collection than the American Community Survey. And as both the ladies said, if you try to go, sub-state, you're going to get more and more problems with looking at that data. So I think anytime you can do your own primary data collection using a nursing survey that can get specific information about where they're practicing, how they're practicing, is much better than using any of these secondary data sources that are out there.
Okay, thank you. And I believe we're out of time for questions. And with that said, Mary Lou, Joanne, Robert, thank you for presenting for us today. And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.